Good morning, everyone. So I think the discussion that we're having here about both leveraging capacity as well as moving forward in child welfare, I think there are really some critical issues that I'd like to raise. And let's see that they actually transferred the wrong slides, but I'll make do. So here we go. So in part, the challenge of understanding the slow uptake of child welfare and EBPs is understanding the context in which child welfare systems really operate. And you can't really do that unless you really appreciate the change in population during the late 80s and early 90s. So as most of you know, there was a very large crack cocaine epidemic. There was increasing concerns about the quality of parenting that was going on in some homes. There was a real concern that the juvenile delinquency was getting to a tipping point and it was going to fundamentally change the way our system operated. And so between 1988 and 1999, the child welfare system in this country doubled in size. It went from around 300,000 kids to around 600,000 kids. Very large increase, done on the premise that we needed to step in and rescue children from really bad outcomes. So totally the right motivation. In 1997, the Congress, being increasingly aware of the increasing costs and size and dimension of the child welfare system, introduced what's called the Adoptions and Safe Families Act of 1997. And that act in and of itself changed the direction of child welfare. It articulated a set of principles that hadn't been enforced at the federal level and set upon a path of significant reform in child welfare. So one of the essential principles revolved around safety and ensuring that children were safe, whether they were in out-of-home care, that they were safe, or whether they remained at home and they were safe. Again, real concerns about the adults involved in the lives of children, real concerns about the system's size and ability to oversee and monitor the children that were in their care. This principle was essential to moving the system in the right direction. At the same time, the federal law articulated an expectation that child welfare and the experience of being in out-of-home care was a temporary solution. Because as you can imagine, as the numbers increased, part of the reason why they increased is very few children actually left the system. Right? And so you had this circumstance in which the parent's right to retain the rights of being a parent competed with the rights of the child to have some permanent outcome. So the system of having courts allow children to stay in care for months and months and months and months and months really changed under this law. The law actually articulated that the child had a right for determination about what was in their best interest if they were in out-of-home care for 15 out of a consecutive 22-month period of time. It said child welfare ought to be a limited temporary experience. Third, they made the case or created the expectation that at the moment a child was removed from home, the process ought to be focused on getting that child out of the home. So in the old system, when it ballooned in size, the expectation or the way the practice existed is you began to think about how do kids get out of the system after the parents had met all of their obligations. So rather than thinking from day one, how do you reduce the number of children in out-of-home care, the practice was to only consider those issues after a determination was made about what the parents' rights were and whether the parents had earned the right to have their children come back to them. And third, there was this expectation of accountability. So for the first time, the federal government articulated a set of outcomes that it would monitor states for. And it began to introduce that standard of monitoring and accountability around 1999, 2000. And what you have as a result of this policy, I would argue, is a significant drop in the overall size of the population. So you see that these numbers suggest that there was a more than 160,000 child reduction in the system. In the early years of this reduction, it was the result of moving children who had been in the system for a long period of time out of the system. And in the later years, it was achieved by decisions around keeping more children at home and putting services in the home. So you can't really understand these numbers if you don't understand the underlying legislation. But it also makes one other point, which is the legislation didn't speak to EBPs. It didn't speak to the social and emotional well-being of a child. Right? And so while we have this collective concern about their outcomes, the policy framework didn't create an expectation, or said differently, the operationalization of that policy didn't require that children actually be served effectively in order to get them out of the system. It was serving them until they got out of the system. And so in a lot of respects, there are states that have developed tremendous capacity to move this. That while I'm calling this a significant reduction, you have some states like the state of Maine that just in the last 10 years have reduced the size of their population by 60%. And most folks in Maine would say that they have been incredibly successful at producing the outcomes that mattered, although they can't speak to how many children whose clinical needs went unaddressed, how they're doing after having been in the foster care system. So if you want to think about how you build or rethink the way the system is operating, you in part have to understand the underlying legislation and the accountability standards that were created. So it's commonly thought that these are actually the requirements of the federal government's, these are the federal government's expectations of states. So as you look at this list, doing appropriate maltreatment investigations, making removals around biological families, caseworker visits to children, training and foster parenting, casework and progress monitoring. These are all requirements that the states understand as their responsibility to the federal government. And so states have also not just been able to reduce the size of the population, they have figured out how to meet these standards. But again, you could meet all of these standards and not actually improve the clinical outcomes of children. If you happen not to be in child welfare between that period of 1988 and 1999, when the numbers skyrocketed, if you came into the system after that, you would understand these is actually the only outcomes that matter. And so part of what the last 5 years at the federal level has been focused on is really rethinking the way the system is organized, and in part, really thinking about how you build capacity of agencies, not just to meet their requirements, but also intervene effectively. And so a big part of that has been around educating states around the importance of addressing the social and emotional well-being of children, to understand the developmental and physical health consequences of maltreatment. It's pointing out that almost 50% of kids in the out-of-home care system have clinical level needs around social and emotional issues. It's also important to point out that of those children that have a social or emotional diagnosis or clinical level need, half of them also have a chronic physical health condition too. So there's this tie between what happens to children before they come into the system that has to be connected with what happens to them when they're in the system. And so a big part of what we did over the last 5 years in child welfare is to begin to try to figure out how to integrate more clinically focused capacity, and how to integrate this emphasis on more effective interventions. And so it means moving away from things that are very, that the market has created as capacity. So if you're a child welfare agency and you need to go out and purchase parenting classes, or you need to go out and purchase generic counseling, or you need to go out and purchase independent living services, it's easy to procure those things. If you want to go out and purchase capacity to screen and assess all children using a validated and normed mechanism, much bigger challenge. If you want to go out on the street and you want to purchase an evidence-based intervention in the communities from which your children are being removed, very difficult to do. If you want to go out and talk about the unique consequences of maltreatment and complex trauma on the behavior of children, and think about how you effectively intervene on issues of trauma, how to go out and purchase those services, very difficult to do, very limited capacity, and in most states you couldn't use Medicaid to pay for that care. Because in most states there's a requirement that you have a diagnosed mental illness before you can access Medicaid behavioral health. Childhood trauma, complex trauma, doesn't rise to the level of a mental health diagnosis for children. And so in many states, if you said what your children were merely challenged with in foster care is trauma-related issues, and therefore you wanted to do work with agencies that have skills and competencies in trauma-based interventions, and you'd like to use Medicaid as the payer, in most states you couldn't do that. I ran a state child welfare agency for 4 years. One of the things that I thought was really important was using standardized instruments for screening and assessing children who were entering out-of-home care. And so we made this commitment to finding the right screening instruments or the right package of screening instruments, and then finding the right capacity and being able to do that for every child that entered the front door within 45 days. As a child welfare director, I paid for all of the screening and assessment myself. Medicaid said that they couldn't pay for that. So that was $24 million. Totally the right thing to do. Difficult to get from the existing policy structure. So these are obviously not quite my slides. I've got two or three other slides. It's not a big deal. I can do them because I brought my laptop up here. So from my perspective, child welfare has two major issues if it's going to be able to succeed in moving towards effective interventions. One of them revolve around educating and building capacity, right? So you've got this whole challenge around educating people around the consequences of maltreatment. And though it may be obvious to clinically trained individuals who may be in the room or people that have an experience of working with really challenging kids and families, but helping to build people's understanding of the consequences of maltreatment remains a critical component to moving child welfare systems. And that means leaders all the way down. Most child welfare leaders work their way up through the system. They don't necessarily have clinical training. It hasn't been a part of the overarching framework itself. And most states don't require clinical training of their social workers or their caseworkers. So you also have the challenge of you have individuals entering a system without the level of training they need to fully understand the challenges and consequences that come with maltreatment. The second thing you need to do around that building capacity is really around the infrastructure. State systems don't know how to procure evidence-based interventions. Medicaid is one example, but there are many others. In many respects, what you're trying to purchase with an evidence-based intervention is an outcome rather than a service. Most state procurement systems don't know how to purchase an outcome. They know how to purchase a service. So they know how to purchase a unit of service. Purchasing a unit of outcome is a significantly different challenge, and building the procurement capacity to do that is critical to succeeding. And then the third component of this, which I think is really important in terms of thinking about building capacity, is seeing the therapeutic nature of child welfare, or the necessity that child welfare be a therapeutic experience from beginning to end, right? So not just thinking about it as a single intervention that's delivered by a clinically trained staff worker, but also making sure the worker, the foster parent, and all of the downstream business practices that I described earlier as federal requirements are focused more towards that outcome and less towards just meeting the outcome, right? So we know, for example, last year that there were 153,000 children who were removed from their homes as the result of a child welfare investigation. I suspect that there was little consideration given to the practice of actually removing that child from the only people they have known, their parents. Right? So thinking about the consequences of trauma, not from a clinical standpoint, from the very beginning of actually removing a child, is part of what the system has to build its capacity to understand and then integrate downstream. So those are really critical issues. And then the last issue that I would raise for us to give some consideration to, and that really revolves around accountability and measurement, right? So I was a part of the Obama administration for 5 years. There was a great emphasis on science and accountability. There was limited attention paid to the accountability that is focused on fidelity to implementation of EBPs. We funded lots of EBPs, but really from a federal standpoint, thinking about how you create accountability systems in the context of an EBP is really, really important and deserves greater attention. Not suggesting that folks didn't give consideration to that, but we didn't have a robust strategy for talking about accountability in that context. And secondly, and related, are the issues around measurement, right? So how do we measure the outcome? How do we know when the outcome we were purchasing was actually achieved? And so there's been limited interest or limited energy focused on how do we standardize the measurement so that we're not measuring each problem with a different instrument, right? So trying to come up with a common approach to measurement is really critical because it's that, I would argue, that it's that standardized measurement of the outcome that ultimately allows one child welfare agency to meet its obligation and have another child welfare agency also meet theirs, because there's a common understanding about what constitutes success because we're all measuring the same kinds of success. So thanks, and I'll get out of your way.